Welcome to this teaching podcast on a rare but clinically devastating placental disease, chronic histiocytic intervillositis, or CHI. Even though it's uncommon, its consequences, recurrent miscarriage, severe fetal growth restriction, and fetal death, make it essential for clinicians and pathologists to recognize.
Absolutely. What makes CHI particularly fascinating is that it sits at the crossroads of placental pathology, immunology, and transplant medicine. Over the last decade, it has gone from being a poorly understood inflammatory lesion to a well-supported model of maternal fetal alloimmune rejection.
Let's start with the basics. CHI is defined histologically. The key feature is a chronic inflammatory infiltrate of the intervillous space, composed predominantly of maternal macrophages.
And that localization is crucial. Unlike villitis of unknown etiology, which affects the villus stroma, CHI is an intervillous disease, meaning it occurs in the space filled with maternal blood. The infiltrating cells are identified using CD68 immunostaining, which confirms their histiocytic or macrophage nature.
Another defining element is what CHI is not. It's non-infectious. Infection must be carefully excluded because infectious intervillositis can look similar but has completely different implications.
CHI isn't a binary diagnosis. Severity matters a lot. Lesions can be focal or diffuse, and pathologists often describe them as mild, moderate, or massive, depending on how much of the intervillous space is involved.
And severity correlates strongly with outcome. Massive or diffuse CHI, where more than half of the intervillous space is involved, is typically associated with severe placental insufficiency.
That insufficiency is worsened by intervillous and perivillous fibrin deposition, which physically blocks maternal-fetal exchange. That's why CHI is so strongly associated with early-onset intrauterine growth restriction and fetal demise.
A major breakthrough in understanding CHI came from immunohistochemistry, specifically C4D staining.
C4D is a split product of the classical complement pathway. In transplant pathology, it's used as a footprint of antibody-mediated rejection. In CHI, C4D is deposited along the syncytio-trophoblastic microvillus surface.
This was a key finding. Studies showed that C4D staining is much more frequent and extensive in CHI than in villitis, strongly suggesting antibody-mediated injury at the maternal-fetal interface.
C4D isn't mandatory for diagnosis, but in equivocal cases, it provides powerful support for an immune-mediated mechanism.
Clinically, CHI is associated with some of the most severe obstetrical outcomes we encounter: recurrent miscarriages, severe IUGR, intrauterine fetal death, and extreme prematurity.
One of the most striking features is the high recurrence rate, often between 30 and 70%. What's particularly telling is that CHI often appears after a normal first pregnancy, then recurs earlier and more severely in subsequent ones.
That pattern strongly suggests maternal immune memory, which brings us directly to the rejection paradigm.
Recent work has convincingly shown that CHI fulfills the same criteria used to diagnose antibody-mediated rejection in kidney transplantation.
Exactly. Mothers with severe, recurrent CHI have fetus-specific anti-paternal HLA antibodies. These antibodies can fix complement, leading to C4D and even C5b9 deposition in the placenta.
Even more compelling, inflamed syncytiotrophoblasts in CHI aberrantly express HLA class 1 and 2 molecules, creating a direct target for these antibodies.
At the molecular level, CHI placentas share gene expression signatures with kidney antibody-mediated rejection, including interferon gamma-driven pathways. This seals the concept of CHI as a true placental rejection syndrome.
So what should clinicians and pathologists remember? First, CHI is rare, but when present, it matters enormously.
Second, diagnosis relies on careful placental histology, with attention to localization, CD68 staining, lesion extent, fibrin deposition and C4D when available.
Third, accurate diagnosis directly affects recurrence counseling and future pregnancy management. Even though no treatment is currently validated, recognizing CHI changes how we follow and support patients.
And finally, CHI is more than inflammation. It's one of the best human models of maternal-fetal alloimmune rejection, bridging obstetrics, pathology, and transplant immunology.
Understanding CHI reshapes how we think about pregnancy complications and immune tolerance.
And it reminds us that the placenta deserves the same diagnostic rigor as any transplanted organ.